Afternoon, everyone, and thank you for joining us today as we discuss driving improved diabetes care outcome and equity and connecting our healthcare partners. Thank you all for joining us today. I'd like to welcome you all and discuss a little bit about why we're here. So the reason that we're here today is to review effective strategies for improving diabetes care and outcomes among Black and Hispanic Latino populations, and also to discuss how they can be nurtured by healthcare payers. If you would please take some time now in the chat box just to let us know that you're here and what your affiliation is and what you do at your payer company, we would love that to capture that information. I'd like to introduce myself. My name is Anna Norton, and along with Leslie Zuniga, who is also moderating today's webinar, we are part of the team at National Minority Quality Forum's Center for Sustainable Healthcare Quality and Equity. And today we're going to be discussing what we do as part of our work at the SHC for short on how we work with Drive Quality QI projects to affect better health outcomes. So I will hand it over to Leslie to take over now.
Okay, perfect. Thank you so much, Anna. And like Anna mentioned, my name is Leslie Suniga. I am the Quality Improvement and Equity Project Manager for NMQF Center for Sustainable Healthcare Quality and Equity. And just to give you a little bit more background about what Anna was talking about that we will be presenting today. So we will be discussing effective strategies and frameworks. You'll also be able to hear from our past and present Drive participants. We will have time for Q&A, so feel free to drop those in the Q&A section, and we will address those at the end. And we also have a special announcement towards the end, so definitely stick around for that. So just to give you a little bit more background, so we are the National Minority Quality Forum. We were founded in 1998 by our president and CEO, Dr. Gary Puckrin, and we are an organization that integrates data and expertise in support of initiatives to eliminate health disparities. And with that, I will hand it back over to Anna.
Leslie. So I would just like to share a little bit about our team. At the SHC, we are a small team, small but mighty, do a lot of different work in health equity. You will see our president is Laura Lee Hall. I serve as Vice President of Community Engagement Projects. Chini Okachukwu, Director of Quality Improvement and Equity. She works very, very closely with our Faith Health Alliance, which is our partnership with churches and community-based faith organizations. And Leslie Zuniga, who you've met, who is our project manager for quality improvement and equity. And Leslie helps to oversee a lot of our programs in diabetes, including our diabetes working group and equity task force. Next slide, please. So where are we? We'd like to first bring up a poll question, just to ask you some questions about what you're thinking. So the first question is, if someone can put up that poll question, what was the total annual cost in 2017 in the United States for diabetes care? If you could just answer, is it 200 billion, 150 billion, 290 billion, or 327 billion? If you could just please click on your answer, we'd love to hear what your thoughts are. And I'll give you a couple seconds to answer that.
All right, we have about 75 people 75% participation.
Perfect. So let's take a look. Okay. So we've got about 40% of the participants saying $290 billion. And actually the correct answer to that is $327 billion is spent annually on diabetes costs each year in 2017. The next question that we'd like to poll you with is, which region in the United States in 2018 had the largest Black Medicare fee-for-service beneficiaries with diabetes? Was it the Southeast, the Northwest, the Southwest, or the Northeast? And if you could just let us know what you think the answer is, please choose a response.
Give it a couple more seconds. We have about 10 more people who can
Thanks,
respond.
Akia. Thank you, Akia, for helping us on the back end.
All right, I'm gonna end it now.
All right, so that is correct. 96% of the respondents said the Southeast, and that is correct. That is the largest region in the United States that has Medicare fee-for-service beneficiaries living with diabetes. So let's talk a little bit about what's going on, right? You can see based off of these maps, this Medicare fee-for-service, you can see that whole entire Southeast region. Very, very red, a lot going on there. And diabetes, affects nearly 40 million Americans, with cases that are increasing among young people, especially African American Black teens. And it's often accompanied by high blood pressure, and chronic kidney disease and other challenges that come with living with diabetes. The diabetes rates are the highest among the Black and Hispanic Latino adults. It's the seventh leading cause of death, with total cost over $327 billion annually in 2017, as we discussed. People diagnosed with diabetes have more than twice the medical costs than individuals that do not live with diabetes. In the Medicare fee-for-service program, as many as 58% of beneficiaries have a diabetes diagnosis, up to 2 times plus the hospitalization rates. And on average, about half of the beneficiaries are hospitalized each year, which accounts for the high cost of the disease. So if we look at the next slide, we can see a little bit more. This portrait of illness and the costs are not sustainable, clearly, and they're not necessary. The ADA Standards of Care in 2023 spoke about team-based patient-centered care that affords treatment options in connection with patients and addresses social determinants of health that can really lead to much better outcomes and quality of life for people that live with diabetes. There's new developments in therapeutics, there's better monitoring techniques. Telehealth is a new thing that we're seeing over the last couple of years, and community health workers or ambassadors that can help to drive better outcomes for patients. So now we'd like to talk a little bit about what we do with our DRIVE program. Leslie?
Thank you, Anna, so much for that valuable information. So we do have a couple more poll questions. Okay, so does your organization plan to launch a health equity intervention in 2024? And if you previously launched a health equity intervention, did you meet desired objectives? So we'll give everyone here a couple seconds to submit their answers.
Still need a few more people to participate. Just hit 50%. All right, looks like we're holding steady, so I'll go ahead and stop it.
I keep trying to touch it, but it won't let me make it.
Okay, well, that's exciting to see that we have 68% that are planning on launching a health equity intervention. That's really exciting to see. And that we have 32% that did meet their desired objective. So that's good to see. I think we're heading in the right direction. Okay, and then we will take a little bit deeper dive into what DRIVE is. So DRIVE stands for Demonstrating Real Improvement, Value, and Equity. So with our framework, we really connect with trusted community voices. So as Anna mentioned earlier, we do have a Faith Health Alliance. So that is a network of 22 churches throughout the country. We also have our Hair Wellness Warrior program. So that is a network of a multitude of hairstylists that are predominantly in minoritized communities, and they all do such a great job at really just, expanding health education within their communities. And then I believe we have a few, we're reaching into our last couple poll questions. Okay, so which barriers have been the biggest challenge to implementing a health equity intervention?
Give it 5 more seconds. Okay.
Okay, perfect. So dedicated resources. Okay, well, as a nonprofit organization, that's definitely something that we identify with. So thank you for those answers.
Do you want to go into, I'm sorry, the next poll question, Leslie?
Oh, yes, sorry, got ahead of myself. We have one more on this section.
Oh, I'm sorry. I think I'm rushing you.
Okay.
Is that what you, or you want to wait?
Yes, that one's fine. So we also want to learn about what disease states you are most interested in addressing with an intervention. So as we'll have a little bit of a deeper dive, we'll learn how flexible DRIVE is and how we're able to apply this framework to other disease states that we work in. So obviously we're having a focus on diabetes today, but there's so many other disease states that our framework can be applied to. So we're just curious to learn what other interventions everybody else is interested in as well. Okay, wonderful. Well, I'm glad everybody's here today then. Seems like we're a great fit. Okay, and then some of the DRIVE goals that we've been able to address with our programs have been reduced A1C levels, as well as other health measures, enhanced patient activation, increased patient knowledge about their disease and interventions, measurements of social determinants of health, in-person and telehealth education, as well as connection to improved nutrition. Okay, and then here we have our framework that can be broken down into 6 steps. So forgive us for our puns. So our DRIVE framework, like I mentioned, can be broken down into 6 steps. So step number 1 is identifying the health system team. So this might be, physicians. We have had pharmacists on the teams before, dietitians, nurses. So really, just setting in plan of who all is going to implement that intervention. The next step is a practice assessment. So this, I think, is definitely one of the most important steps in our framework. So this practice assessment really lets us, identify barriers within the health system, barriers that, the patients that are attending the health system, might be facing. We're also able to learn, what community engagement looks like. Really just trying to tailor down that project and seeing, what social determinants of health we could also tackle while we're there. And number 3, again, learning about the community. So again, just really putting that focus on social determinants of health and seeing, what the community might benefit from the most, and even, what the strengths are within the health system, what resources, what tools, programs, things like that, that we might be able to, highlight or maybe just put in a little bit more work to make their resources, have a bigger impact. And number 4 is our designing activity section. So this structure that we follow is a Plan, Do, Study, Act structure, so PDSA. So this really works on many different changes. So we use this from, improving protocols to even executing new workflows. And with those workflows, we definitely try to see, what gaps there are. Like I mentioned earlier, the barriers that we're seeing, whether that be, time for physicians, within the health system and all that kind of stuff, and just seeing how we can address them and really put them into a design for a great activity to do. And with our PDSA cycles, we do PDSA cycles, so that might be something that goes between 2 to 4 months. And we'll try to do multiple cycles, just kind of pending on the time frame that we have for our programs. And we can always repeat a cycle as we get a little bit further along in the program. We always try to be very flexible, just to make everything sustainable as well for our health systems. Step number 5 is putting the plan into action. So usually what this might look like, it kind of depends per health system and, what strategies they might already have in place. But the plan might be released to the rest of the health system. This might be during a lunch and learn, a webinar, a large meeting, something like that, just to disperse the education and the plan. So everybody within the health system is on the same page. And this is also a good time just to also review any other resources within the health system, that we can also expand on. And step number 6 is communicate, celebrate, and continue. So, definitely celebrating our wins through our programs. We try to, do some sort of evaluation as the program is coming along, not just towards the end. This way we're able to learn. And like I mentioned, we follow a PDSA structure. So if we reach, we're nearing the end of the program, we still have some time to implement another activity. Then that's something that we can always look back on our evaluations that we have done and see which area, we might need to put a little bit more focus on, or, if we had a really successful cycle, we might want to repeat that again. Okay, and then just to shine a little bit of light on a really important factor in our programs is the sustainability factor behind it. So we are doing a lot of the background work and the framework, obviously, but really who is making all these changes and who is implementing and leading all of this is the health system itself and our community partners. So we find that that's, really the most sustainable approach to our programs. And also, just keeping in mind that we also must be flexible and be able to customize our programs. We always say that equity is not one size fits all. We try to make our framework as translatable as possible to other disease states, and especially since we work in such diverse communities. So what works in one health system might not work in the next one, or, even just city by city, community by community. We always try to be as flexible as possible. And sustainability to us, that might look a little bit differently everywhere that we go. That might be, once the program ends, the whole program in and of itself, every single step might not continue, but there's oftentimes multiple factors of those programs that are left over that they continue later on. Another sustainability factor that we look at is just the continuation of relationships. We're able to build long-standing relationships with multiple health systems. And, we're always more than happy to loop them back in on, we're doing a lot of flu programs. So our drive flu programs, we're working in the cancer space now. So those are health systems that we reach back out and bring that back into our drive programs. So, I think continuing relationships is also just very, very important to, continuing the equity work. And just some other information that I wanted to provide on our sustainability side of things. So we currently have a Drive Diabetes program in Oakland, California. So here you can see our table. So this is medication adherence levels. So 2022 was before we started the program. 2023 is our midpoint. So here we can see the medication adherence. This change was made possible due to a workflow that was implemented. So this workflow really just incorporated diabetes self-management education into rechecks with patients. So really just making changes like that, kind of a safety net for these patients, just to be able to follow up a little bit more and get that education needed. They've been able to increase the medication adherence for their patient population. And this is just halfway through. So I'm really excited to see how this is going to, keep going up towards the end of our program next year. Another factor that we are really happy about, just really highlighting our sustainability, is the connection that our Oakland Health System has been able to make with our Faith Health Alliance church that is near them. So one thing that the hospital reached out to us was that they have food distribution events, and they're really limited on space. They're hosting these in the parking lot. So something that we were able to connect them with was our Faith Health Alliance member. And, they offered up the parking lot, and that, was really a big change that was able to, they were able to host a lot more individuals. So they've seen about a 200% increase in attendance. They've also been able to increase their vendors that they have at the events and resources as well. Okay, and with that, I will hand us back over to Anna, and she's going to introduce some of our drive participants, our community partners as well. These partners have worked in diabetes programs and flu programs, so just a really big diverse group of people here that we have. Thank you.
Thanks, Leslie. And thank you all for listening in and learning a little bit more about Drive. But now we're really going to learn about the stories, the driver stories. And first up, we have Dr. Dominic Galante. He is the Chief Medical Officer for Precision for Value, and he's going to share a little bit about the involvement that payers can have when it comes to sustainable programs like Drive. So the next slide is going to have some questions that we've posed for Dr. Galante, and he's going to be to answering those. Thank you so much. Welcome, Dr. Galante.
Thank you, Anna. Glad to be here today. So I've been asked to provide a peer perspective for our discussion today, and there are 3 questions here noted in the slide, which I'll address. And if we look at the first question and consider why it's important for payers to support quality improvement and equity projects that have demonstrated to be effective strategies, I believe that it's important for payers to support quality improvement and health equity projects for a multitude of reasons, not the least of which include reinforcing their commitment to the evolution of the triple and quadruple aims to the current quintuple aim, which adds a health equity goal to the overall aim concept, but also to advance the adoption of value-based care delivery and reimbursement models. So a payer's adoption of value-based care journey to health equity strategy can be achieved by and sustain quality improvement through physician-led engagement, as well as established infrastructure, delivery of increased patient-centered services and value-based care programs, direct engagement in accreditation certification programs that recognize the value of health equity. And for example, the National Committee of Quality Assurance, the Joint Commission, CMS, all have programs and have requirements that have to be met and focus around health equity and social determinants of health. And then exploring or preparing for new value-based care delivery models. And for one example would be around oncology. We have the evolution of the oncology care model to the enhancing oncology model. So at the end of the day, payers are focused on achieving improved patient outcomes and enhanced patient experiences, while reducing total cost of care, which can be further enhanced with an emphasis on engaging successful health equity strategies. If we go to the second question regarding why payers need to support community-based programs, well, there continues to be growing recognition of the relationship between neighborhoods and health, with zip codes recognized to be a stronger predictor of a person's health than their genetic code. A number of initiatives focus on implementing coordinated strategies across different sectors and neighborhoods with social, economic, and environmental barriers that lead to poor health outcomes and health disparities. So for example, the Harlem Children's Zone, or HCZ project, focuses on children within a 100-block area in central Harlem that had chronic disease and infant mortality rates that exceeded rates for many other sections of the city, as well as high rates of poverty and unemployment. The HCG project seeks to improve the educational, economic, and health outcomes of the community through a broad range of family-based social service and health programs. Another example is the collaboration between Geisinger and the Central Pennsylvania Food Bank that established the Fresh Food Pharmacy Program to address food insecurity. So I believe that it's imperative that payers who are part of the communities that they represent as well as serve need to support community-based organizations and programs, since these community-based initiatives focus on implementing cross-sector strategies to improve health in neighborhoods or communities with historical poor health outcomes. And finally, the third question, what should payers look for when supporting quality improvement and equity projects? Well, I'm going to focus on health equity projects, since these are less common than traditional quality improvement initiatives or projects that you may all be familiar with. So payers should look for an established as well as clearly articulated health equity strategy, which conveys two major elements consisting of partnership and action. Partnership may comprise of the following attributes: initiating conversations with various key stakeholders, providing education to staff, establishing partnerships in the community, and considering patient experiences. An action may comprise of demonstrating organizational commitment, determining what is measurable, developing a strategy and implementing the plan, and finally defining a path on how to influence public and private policies. I also want to share with you an example of a 7-step multi-stakeholder health equity strategy implementation plan that I've experienced to be effective with payers, where the first step is to identify demographic data completeness, which will be added to a screening tool to identify vulnerable populations as well as their needs. Second step is to select the social determinants of health screening tool and also to define its utilization. Third step is to establish an assessment outcome follow-up plan as well as a timeline. Fourth step is to define all stakeholders and develop a communication strategy and plan. Fifth step is to set it in measurement periods and guidelines. The sixth step is to conduct staff training education. And then finally, the seventh step consists of developing sustainability and continuous improvement plans. So as mentioned earlier, we'll have a Q&A session at the end of the presentations to further elaborate on our perspectives and projects. So at this time, what I'd like to do is turn it back to Anna.
Thank you so much, Dr. Galante, for sharing your insights and your expertise on these kinds of programs. Now we're going to move and introduce you to Maggie Malone. She's the Director of Nutrition at the Urban Health Plan Plaza del Sol Family Health Center in Queens, New York. Welcome, Maggie.
Good afternoon, everyone. Yes, my name is Maggie Malone. I'm the Director of Nutrition at Urban Health Plan. Urban Health Plan is a network of community health centers in the South Bronx, Corona, Queens, and Central Harlem. In 2022, UHP saw 83,568 unique individual patients with over 434,000 total visits. Thanks to our funding from the National Minority Quality Forum, we were able to provide virtual diabetes self-management classes to our uncontrolled diabetic patients at our Corona Queens site, Plaza del Sol. Now, Urban Health Plan's Corona Queens patient population are primarily Latino with a predominant South American background. They are mostly uninsured and Spanish-speaking with very high rates of uncontrolled diabetes. The program we developed was a virtual nutrition education workshop session. We provided education on diabetes self-management and healthy lifestyle choices to this population. The patients that participated in the past 6 months at our Queens location and all had A1Cs of 8% or above. What did we do? We facilitated 5 virtual diabetes self-management classes for our Plaza del Sol patients that all had the A1C of 8% or above, and these classes were led by bilingual registered dietitians. For our recruitment, we obtained a list of the patients who met the clinical qualifications, and these patients were invited to the virtual education session via text message. The first 145 patients to attend the class and complete a pre and the post test received a supermarket gift card incentive. The gift card was to be redeemed at a local supermarket for healthy food only. If our targets for attendance for the classes were not met, patients were provided the diabetes and nutrition education during one-to-one nutrition counseling sessions with a nutritionist, and they also completed a pre and post test. We measured several outcomes. We collected the number of patients that attended the class, those that completed the pre and the post test, the number of gift cards distributed, and the overall change in patients' knowledge. We had 102 patients total. 93 patients attended the virtual session and 9 patients attended the one-to-one session. We saw a significant impact on A1C for both of these patient populations. For our virtual participants, 36.4% of the patients that attended had a 1% or more reduction in A1C. For the 9 that finished the sessions in one-to-one, had a 33.3% had a 1% or more reduction in A1C. We also saw that the patients that received the one-to-one education during the nutrition session had a better outcome on the post-test. We did see several barriers during this program. One of them was recruitment. So recruitment via text message was a challenge. Not all of the patients received the text message. A lot of the patients had disconnected phone numbers or were out of the country during the pandemic. It took a lot of time and clinical resources. We conducted the pre and the post tests over the phone and had to rely on our clinical staff to conduct the pre and the post tests. And scheduling. Barriers related to employment were prominent. This patient population works 6 days a week. They work all day, every day. So finding a time for the virtual sessions to get the greatest participation rate was a challenge. And technology. This patient population was not familiar with Zoom at the time. So it was challenging for them to click on the link. And also a lot of them were concerned about using their phones to participate because they didn't want to use all of their data. Otherwise, we saw during these presentations and during the sessions, when patients came to pick up the gift card on site at the clinic, they were very grateful. They desired more education, and they also had the opportunity to get the COVID vaccine. So it provided them the opportunity to get vaccinated, and we provided them other resources as well.
Thank you so much, Maggie, for sharing that comprehensive, backdrop story about what you did at Plaza del Sol. I think it's very, very interesting to share the successes and some of the challenges and the barriers that you face and how you were able to overcome them as a system, right, as a clinic. And that you brought up some very, very poignant points about overworked staff, and perhaps when we're thinking about sustainability, figuring out ways to alleviate some of the pressures of the clinical staff, right? Which I think is a great segue, because I'm going to introduce Fred Spry now, who is a community health worker and the owner of the Shop Spot, and he is a member of our Hair Wellness Warrior program, which is a program where we have stylists and barbers reaching out to members of the community while people that live with chronic illnesses and disease states are sitting in the chair. And Fred is going to chat a little bit about his role and the work that he does as a wellness warrior, a hair wellness warrior, and speak about the programs that he has run in his shop, not necessarily for diabetes, but for other disease states. And also, Fred, let us know why you think it's important for others to know how important it is to support your community-based program. So welcome. Thank you for being with us today.
Good afternoon, everyone. I'm Freddie Spry. Like you said, I work with hair. I've been working with hair program for about 12 years now, and been working as a wellness warrior at the beginning of the pandemic and through, and still working on a lot of different chronic diseases in our neighborhood and our communities. It's very imperative that we get this information out to the community. And one of the best ways we've done it so far is through the barbershop and through our relationships with people in the neighborhood and community and clients as well, and then friends and family. It's very important for people to have information at their hands to stay healthy, of course, but stay away from diabetes. It's one of the highest killers in our community. I have many family members that have diabetes type 2. And the crazy thing about diabetes type 2 is it can be prevented by just diet and exercise and many other things. It's very important that we have our community engaged in these things, just informing them with the information to stay away from becoming diabetic. So far, it's been working a lot, even with myself and my family members, hands-on, and everyone that we touch. We're working with with the Wellness Warriors. We're putting together a diabetes prevention plan. This been phenomenal. A lot of people accepting it and very happy and very motivated to stay in shape, and those that are not in shape to try to get in shape.
And Fred, at the shop, you have done some programs based on flu, I believe, and lupus. Can you share a
Oh.
little bit about them?
Well, we've been diabetes, heart diseases, heart attacks, flu vaccines, COVID vaccines, a number of different things, hypertension, high blood pressure. We've done so many different things. Dr. T can explain even better than me because he's the big brother that I had who brought me on this and gave me the education and got me to where I am today to be able to help my community and my family and friends.
Thank you. And we're going to bring Dr. T in when after our last speaker speaks, just when we open it up to Q&A, and he can share a little bit more about the Hair Wellness Warrior project and what the salons do out in the community. Okay, thank you so much, Fred. We're going to move on to Amy Harris. Amy Harris is the Chief Implementation Officer and Associate Director of Ambulatory Care at New York City Health and Hospitals in Elmhurst, New York. And she's going to share about the program that they do and share about the quality improvement work that has been done. They do a lot of great things at the hospital. We always get to hear these wonderful stories. So I would love for you to share them with our audience today. Amy, welcome.
Oh, thank you for having me today. It's wonderful to be here with all of you. I am, as you mentioned, Chief Implementation Officer, and people always ask me, what does a Chief Implementation Officer do? And my job is to implement all the projects and the good work of that we do with National Minority Quality Forum. So one of the things that we had done last year, one of my roles as the Chief Implementation Officer, I'm also the flu vaccine coordinator. And throughout the pandemic, everyone was wearing, the mask. And while we were doing a good job getting our patients vaccinated, we weren't doing a very good job reminding everyone to get flu vaccines, particularly with the employees. The employees were, I would say vaccine fatigued. I don't know how else to say that. I don't think anyone wanted to talk about vaccines. So we were really looking for a way to partner with our friends here at National Minority Quality Forum and think about how can we be creative with, making healthcare fun again, really getting people back to the table about getting vaccinated, because flu is something we still have to be very concerned about. And last year, interestingly enough, we had a very early flu season. Luckily, what we had done is we had been very engaged, and we decided, okay, we're going to do something. We're going to have a very centralized flu vaccination center. We had extended hours. We were running, long hours in the very beginning. We made it easy. You can schedule yourself online. In the very beginning, we could not handle, we have over 6,000 employees. We could not handle just a walk-in, but we had a very simple log on, schedule yourself, because if we did walk-in, we would have hundreds of people come during lunch hour, and that we could not manage. So we did have an online scheduler, and throughout the season, we ended up really, we went the 2021-2022 flu season, we only had just over 32% of the employees vaccinated, which was pretty pitiful. It was, you know, just not very good for a hospital of this size. So, you know, my goal was like, well, let's try and get to 50%. I mean, you know, it would have been a huge stretch. Like this year, my goal is to get to 80%, but I'll tell you why. So we were looking at really innovative ways to engage the staff. So we had a centralized area, and I think initially you get those, you know, the people that are like, yes, I'm going to go get my flu vaccine. And then, you know, that demand kind of, it peters out, you know, after the first 3-4 weeks, you know, especially that first 2 weeks, there's like, you know, mad crazy demand. And then it kind of, you know, by the time you get into November and getting closer to the holidays, it kind of fades away. So we decided, okay, we're going to do something really neat. We started giving out, we had incentives. The first 500 people got these amazing t-shirts that said we had a logo, and the first 500 people got t-shirts, and they kind of did the job of marketing for us to the other employees because they were allowed to wear them. So if they had a uniform, we allowed our CEO and everyone, our COO allowed them to wear their t-shirts during the flu vaccine season as our internal marketing. And then the next 500 people, and they were one of a kind. That's how we marketed, one of a kind, limited edition. If you weren't there and you missed it, that was it. There were no more orders. So that incentivized some people. And then the next 500 people, they received, this is this year's pin. They received a pin like this. A lot of people put them right on their lanyards. It seems like we have these lanyards and people like to collect pins where we have different celebrations. So people wore the pins. And then what really came down to when the demand started to lessen, but we saw that there were still not enough employees getting vaccinated, we came up with something called the Flu Ferry. And the Flu Ferry was really something that was born out of meet employees where they are. You know, I was always someone who's like, oh, I gotta go walk all the way over there, but I'm over here and I've got so much to do today and I have so many meetings. So I thought about it around, I think it was around Halloween, because I went to the store and I bought wings. And we got one of the clerical staff to wear the wings, and we had an online system where anyone could sign up their department to have a visit from the Flu Fairy, which was kind of like the Tooth Fairy, but the Tooth Fairy just takes a tooth. The Flu Fairy comes and brings you an immunization, but she also brings a gift similar to the Tooth Fairy. So we had managers and staff members signing up their departments for different days during the week. And we didn't do it every day because it depended on now when we had staff available, but we created the Flu Fairy with her team of nurses and another clerk, and they would have workstations on wheels, and they would go and they would have their, you know, flu caddies. And they would stop in a department, and for the next hour, they would vaccinate, they would register the staff, vaccinate them, and then they would give out little giveaways, little things of candy, whatever we had available as incentives. And that was fun. The staff liked taking their picture with the Flu Fairy. They really, you know, enjoyed it. If they were working on a spreadsheet or even on a call, they'd be like, I'm going to put you on hold for a minute. They put someone on hold, run over, get their vaccine, receive their gift. And we were loving it because we were seeing every week our vaccination rates climbing to the point where Elmhurst Hospital, we are part of New York City Health and Hospitals. We're the largest public hospital system in the country. We ended up giving out more vaccines than any other hospital in our system. We did better than the year before, certainly not where I want to be, but by the end of the season, remember, we were all still wearing masks. We had 59% of the employees vaccinated. So we were just under 60%, which was, for me, I was like, oh great because last year we were at 32%. It wasn't quite double, but it was such an improvement. We were so excited. And by the end, people were really, talking about it, and already, we've already planned out for this year. We actually start in 2 weeks. I think we got about a 2 or 3 week break before we had to start planning for this year. So for sure, we will have the Flu Fairy back. I've had a number of requests for the Flu Fairy to return with her team of vaccinators. And we have a new logo this year. He's wonderful. He's I guess I can show it if I can find a quick picture of him. But we're looking at bringing this back. The best way to engage with National Minority Quality Forum is to really think about, how can I be creative? How can I use data to motivate my team that's doing the work? And then how can we use the collaboration to really become creative with doing this? And I know some of these ideas may sound a little hokey, but if you really want your staff to engage, this is something you have to really think about. I think that our employees don't always want to do these things. This year it's going to be a little different because I think the system overall is going back to, if you're not flu vaccinated, you're going to have to wear masks. So we're going back to pre-COVID mask restrictions. So that may be the driver that gets us back to 70-80% compliance, because I think there are a lot of people that have enjoyed the last few months of not having to wear a mask all the time. So we'll see what happens, and that's where we are now.
Well, thank you, Amy. And I love to hear the story about how you inspire your staff to vaccinate, because it does create a teamwork sense of growth, better morale in the workspace, but then also that really provides better attention to the patients, right? Which is what we're always thinking about. And so congratulations on incentivizing, on being creative, on nearly doubling vaccine rates among your staff, and then setting goals even higher for the following years. That's very commendable and a wonderful way to use the programs, the DRIVE program, to your advantage for your employees and, by extension, to the patients. The last person that I would like to introduce and invite to share his screen is Reverend Robin Toogood II. He is another one of our Faith Health Alliance partners at Purity Baptist Church and Urban Center in Washington, D.C. And Reverend Toogood is going to discuss a little bit about why it's important to support the trusted community partners, especially those that are faith-based. And then he's going to share with us the next steps, what's coming up after this call today. So welcome, Reverend Toogood. It's nice to have you.
Good afternoon, and it's certainly a joy to be here with all of you and to be on this prestigious panel and to share in the conversation that is going on that has been impactful to this point. And we hope that these few words will certainly enhance the impact that is being made. As a senior pastor of the Purity Baptist Church and Urban Center, located in the Capitol Hill neighborhood of Washington, D.C., I have had the opportunity to serve all of my life here. I've been the pastor the last 15 years, but this is the church that I grew up in. And I have seen over time how the neighborhood, the work, the different things around us have changed for myself and for those who are parishioners. And one of the things that I have learned in these last 2 years that I have been connected with the National Minority Quality Health Forum, which has been different than all of the years that I have been able to work with or be a part of my congregation, is that there has been a new added power behind the punch and the impact that we try to make in our neighborhood. We as a church certainly have, I would guess, the the stronghold on the thoughts and the mindset of the people around us. And with being within the community, serving the community, my church has multiple programs that we serve. We have a good our thumb on the pulse of what's going on. And yet, with all of that being said, there still needed to be some power behind that impact. We can certainly direct the impact, but there needed to be power behind it. And that's why partnerships with persons who are making these kinds of choices, making these kinds of decisions, the persons that have shared today what National Minority Equality Forum brings to us, the health care needs of those in our community, Black and Brown, and specifically targeting those needs in a way that brings about a change is what provides the power for the punch. We've been punching all of these years. We've been punching for 76 years. But the power that has been provided now certainly gives a new level of impact and a more deeply embedded kind of assistance and a more deeply rooted kind of work that really is making a difference in our community. We have persons that, I mean, even when you get some of the things like persons in, going to drugstores and that, bringing it to the place where they come anyway to get their food sources or to get things that they would want more of a need. Having the idea that you can also stop at this particular place and get whatever healthcare need you might need met at that time. Having that level of partnership makes such a difference, and it creates for both the community partner and you who provide the resources. It creates that level of intentionality and the level of sustainability that you really want to see. And so for me, we leave it feeling like we've done all we can, but for all of us, we have touched a level, we've touched a population that maybe we would not have been able to reach any other way. And because for me, I would not have had the resources to do it. And maybe there might have been some way that others may not have been able to connect. But with us being able to connect and with the resources being provided to be able to do it, what a unique ability we have now to create a different trajectory. I'm talking about a significant paradigm shift for persons who may not have been able to, or, and you don't have to even say may, you can look over time and see that they have not participated in a way that they do now because of these kinds of partnerships. So it's a great thing, especially when it comes to their health, because we realize that our communities sometimes lag behind in taking care of and responding to health needs. And so when you've got this kind of work going on, when you've got this kind of intentionality, when you've got persons who are really significantly attempting to make a difference, change happens. Now, I do want to invite you, if I can. I've talked about the power behind the punch, but now I want to invite you to roll up your sleeve. On November the 2nd, we're going to have a flu vaccine drive in our church, and we're going to invite the community, all of those who are here. I do believe that you all, we certainly are rolling out the red carpet for you to come. And in fact, we're not just rolling out the red carpet, we're rolling the blue, green, yellow. All carpets will be rolled out so that you will feel the most welcome in our place. And we want you to come and share with us in this flu vaccine. You have a meeting, and I believe there'll be food provided and all of that. But then beyond that, we want you to roll up your sleeve and get your flu vaccine right in the same place. We want you to see in action what your resources are providing. We want you to see in action the kind of impact that you're making. We want you to see in action what happens when community and health partners come together, what kind of true impact for populations that really live on the margins of life can be made. We want you to see it. So you join us on November the 2nd. I believe we're beginning at 11 o'clock, from 11 to about 2, I believe it is. I may have the hours wrong, but I want you to be here and to share with us. Again, we're not just rolling out the red carpet, so red is not your color. Whatever carpet you need to see, we're rolling it out so that you'll feel welcome in our sanctuary. God bless you, and thank you for this opportunity to share.
Thank you so much. Thank you so much, Reverend Toogood. And with that, that concludes our driver stories. But I do want to reiterate, the Purity Baptist Church is opening up its doors for a follow-up meeting that we will be having for this group of payers. So please mark your calendars. We will send an invitation sometime next week for a follow-up meeting where you can come in person, continue to have conversations about the DRIVE program and how you can get involved. And then, as Reverend Toogood said, you could roll up your sleeve and stay, be a part of the DRIVE program with the flu vaccine clinic, roll up your sleeve, get vaccinated, see how the community comes out, see the power of community-based and faith health organizations coming together with the National Minority Quality Forums, SHC, so to bring health outcomes to populations that are minoritized. At this time, I'm going to pass it back to Leslie, who's going to open it up to Q&A if you have any. I know that we're almost at time, but if there are any questions, we would love to answer them. Thank you very much.
Yes, if there's any questions or anything that you think about later on, feel free to email us. I do believe I skipped over a poll question. Okay, I don't know if we have time to bring that up. If not, we can always touch base on that later. But yes, if there's any questions that anybody has, we are more than happy to answer those.
Yes, I can bring up the poll, and Dr. Thomas did have his hand up.
Yes, and we'll have Dr. Thomas, who is with the University of Maryland, and he is with our Hair Wellness Warrior program.
So Dr. Thomas, I have unmuted you, and then we can do the poll.
Thank you very much. Are you able to hear me okay?
Yes.
Well, this is just very quick to say thank you. Thank you to Sanofi for making this possible and the National Minority Quality Forum. And I don't want anyone to miss the magic in that lineup. I don't know if you go back to the lineup of the speakers to recognize that, look at this mix here. We have some of the usual suspects, our payers, our hospital systems, and then look at our new partners, you know, the faith community, Purity Baptist Church, and Fred Spry with the Wellness Warriors. That's the other sacred space in the African-American community, the barbershops and the beauty salons. And they were mobilized during the pandemic with over 1,000 shops now in our network. And these barbers and stylists have been trained as community health workers and certified lifestyle coaches. So we have a new doorway to reach our community. And I think that these are the silver linings of the pandemic. And I'm so glad that we're having an event like this to share those silver linings and to keep us all together. So that's my shout out to all of you who organized this, that this is the way we go forward with the lessons learned from the pandemic. We are going to leave no one behind. Thank you very much.
Thank you.
Thank you so much, Dr. T. And I will actually drop the link for the Hair Wellness Warrior. They have a newsletter. So let me pull that up real quick and I can put that in the chat. So you guys can sign up and get updates. And they also put on a show, just a health educational show. So I think that's always really good to share.
In fact, we're live tomorrow on our Zoom town hall, The Cutting Edge. And the topic is breast cancer awareness and prevention.
Okay, so there is the newsletter link, but I just wanted to thank everybody for joining us. And here is our last poll question as we start heading out. So how would you like pharma manufacturers to assist you with your health equity intervention / ideas?
Give it a few more seconds as people are exiting. Actually, not exiting.
Perfect. And I do want to thank our partners at Sanofi for their collaboration today on today's event. And then, like we were saying, just keep an eye out for another invitation for our in-person event on November 2nd at the Purity Baptist Church. And perfect. So provide a network of like-minded organizations. Well, perfect. Well, thank you so much, everyone, for your time. Everybody have a good rest of your afternoon. Thank you.
Thank you. Bye-bye.